Before I start, I just wanted to know, we do ELISA for diagnosis of HIV in adults, right? And we confirm by a Western blot. Children less than 18 months, we can't do an ELISA because maternal antibodies are present, and so we need to do PCR in infants less than 18 months. Otherwise, we'll get a false positive ELISA because of the maternal antibodies. So we have to do a PCR in them. More than 18 months, we can do an ELISA. Now, this is an example. 27-year-old woman, she comes to us. She's pregnant. She's diagnosed with HIV positive in the 3rd month of pregnancy. So we started on Ridovudin, treatment for prevention. She undergoes a cesarean section so that we don't have any vaginal delivery or vaginal secretions contact. Baby is born okay, little low birth weight, but born okay. Baby receives Ridovudin for 6 weeks so that baby gets a prophylaxis. And we do not give breastfeeding because again we know that HIV comes through breastfeeding. So we do not do that. So she has received 4 arms. Ridovudin to mother, cesarean section, Ridovudin to baby, and no breastfeeding. Now, this child at 4 months we see her. She's not putting weight. She has liver spleen calculus. She has generalized lymphadenopathy. She has got delayed milestones. So most likely now very encephalopathy. And she's not thriving well. At 4 months also she's just 3.5 kilos. So we are suspecting this child has HIV. Now we did our PCR which was positive, and we did a viral load. It came as 5 lakh copies. So this child is positive, needs treatment. So we started our own treatment. We started on Ridovudin, Lamivudin, Levoripine. 1 month later, your question on Iris. This child had a BCG adenitis. Her immunity came up. The BCG formed a lymph node and adenitis, so we gave her AKT for that. 1 year, 11 months, this child was still not doing well. So she had failure to thrive, she had delayed milestones, MRI brain was normal. Now in this child, the cause of her delayed milestones was the maternal AZT given, Ridovudin given. That is known to cause lactic acidosis, and there have been reports of mitochondrial dysfunction in these babies. So this child developed that. She was HIV ELISA positive at 19 months of age. She's positive. And viral load is undetectable. So she's well controlled now. But she is positive child. At 2.5 years, she starts gaining weight, milestones start improving, so cerebral palsy improves, spasticity decreases, her viral CD4 count is 24%. Her ELISA is still positive, we do that. Her viral load is 2,000 copies. Now 2,000 is just a small blip. You don't really take this into consideration as a drug failure. Just a small blip, so you continue monitoring. Now this child, I'm just telling you the test, what has happened over a period of time. She's 5 months, her CD4 count is 190, 440%, 44%, viral load is 5 lakhs. At 1 year, 11 months, her CD4 count is 1000, her viral load is undetectable, her ELISA is positive. At 2.5 years, CD4 count is normal, viral load is 2000, and her ELISA was positive here. Subsequently, over a period of time, we have been monitoring her CD4 count, which has fluctuated but has remained almost the same. It's not a bad CD4 count. I mean, to have a 57% is a good CD4 count. Now at 5.5 years, because this child is a spastic child, she decides to go for an orthopedic corrective surgery. So she goes to RGLE Orthopedic Center, and they advise her to do a free of HIV ELISA. So she goes to RGLE for a free of HIV ELISA, which they do in a private lab, and it comes negative. So now they come running back to me saying that, was this child all the time negative? Okay. So we said, no, you repeat from our lab and see. So we repeated the ELISA from our lab, and it showed a low positive. Okay, it's an indeterminate titer. It's neither positive, neither negative. So then we were confused as to what is happening. So we repeated from another lab, which uses a 4th generation ELISA, and the titers came high positive. So we said, no, you are positive, there is no problem, this is definitely. So then, why did that private lab have a negative report, and why did we have an indeterminate report? Can anyone think of a cause? So these are the problems. I'm telling you, we are labeling a child positive. These are going to be problems you're going to face. ELISA is always based on a titer. Though you get the report as positive, negative, just as you do torch titers, You have certain values, less than 0.9 is negative, 0.9 to 1.1 is indeterminate, more than 1.1 is positive for a torch. Similarly for HIV ELISA, there are certain titers. So anything in the grey zone is known as indeterminate. Now if you have a perinatally exposed child, maternal antibodies are there. If we do the ELISA 2 months high titer, then the antibodies wane off. So 8 months lower titer, 9 months lower titer, 15 months lowest. Now in this child is 5.5 years. Why did that HIV ELISA become indeterminate?
Viral load was less.
Viral load is undetectable.
That's the reason.
So possibly the child has started waning of the antibodies over a period of time. Because the child is so well controlled that the antibodies don't need to be on a high titer to maintain the immunity. So maybe the antibodies have started coming down, and that's why most of the ELISAs didn't pick up that antibody. The private lab that did an ELISA was a third generation ELISA. Third generation ELISA is not very sensitive, not very specific. So if you have low titers of antibodies, it will come negative. So whenever you ask for ELISA, ask for a fourth generation ELISA. Try this thing. So ask for a fourth generation ELISA.
Why they are not doing fourth generation directly? Everybody.
It's a newer kit. Maybe they still have the stock of the old kit. So ask for a fourth generation ELISA. So that's the moral of the story. These are the diagnostic problems that we face. So this was what we got, negative outside lab. Our lab indeterminate 0.36 titer. And we did from another lab it was 0.68. So it was a positive child. So this child, parents got really happy, oh HIV got cured. Okay, it's not a cure. Remember this child PCR is still coming undetectable.
What about ELISA for false positive?
Agreed. So now we'll come to that. Next case. Okay, so you have to check for fourth generation ELISAs for doing HIV ELISA. And you have now newer generation ELISAs which actually not only check for antibody but check for antigen. So it checks for both antibody as well as P antigen, P24 antigen. So that is known as a duo, HIV duo combination. So that is even more sensitive than just doing an antibody test. Rapid test you get Tridot. Tridot is most unreliable. Okay, so don't use Tridot. Tridot is done in an emergency where a resident got a prick and wants to know HIV ELISA prophylaxis to be started or not to be started. That's the time you do a Tridot. Otherwise not to do a Tridot. So now we come to our next case. Okay, I'm going to skip all this. Now we come to PPTCT. Now let's go to PPTCT as a case. Now this mother has come to you at 4 months of gestation. She is HIV ELISA positive. What will you tell her? What will you tell her? She is positive, tested positive. Okay, we confirmed it with a Western blot, and we confirm it either by repeating an ELISA or by testing blood. Second thing is you have to screen the husband, whether he is positive or not. So this mother's Western blot was positive, so mother was also confirmed to be positive and husband is also positive. Now what next? You do CD4 and viral load. Why do you want to do that? To start treatment. Okay, so one option is whether this mother is symptomatic and we do a CD4 and viral load, and whether we need to start treatment. Okay, but we also have to counsel her about her pregnancy, right? What are her options? So whether she wants to continue pregnancy, does she want to go for an abortion? Does she want to continue pregnancy? Then what are the chances of transmission to the baby? And if she undergoes treatment, what are the chances of transmission? So the options that you offer to her is medical termination of pregnancy, transmission rate 0%, right, with medical termination of pregnancy. Or does she want to take ART or antiretroviral drugs? Then does she want to do a cesarean section, or she wants to do vaginal delivery? Does she want to breastfeed a baby or not breastfeed? So does she want to continue her pregnancy? If she wants to continue her pregnancy, what are her options that she is going to do? HIV comes from the mother to the baby in 3 ways. Either intrauterine through the placenta. At the time of delivery, when the baby is coming out through the vagina, a lot of fluids come out. So at that time the baby can take in the fluid and get HIV, or through breastfeeding. So we have to offer her the options. We have to tell her, you take the drugs so that intrauterine transmission becomes less. Do you want to do a cesarean or do you want to do a vaginal delivery? And do you want to breastfeed the child or not breastfeed? So depending on that, we have to tell her it's going to be 5%, 10%, 20% chance of the baby getting positive. If she is going to breastfeed, her chances of getting a positive child will increase to 15 to 20%. So ideal is no breastfeeding. If we give the mother drugs and her viral load becomes less than 1,000 copies by the time she is ready to deliver, even if she does a vaginal delivery, it's not a problem. Because there won't be any virus in the vaginal secretions. So if viral load has come down to less than 1,000 and she does a vaginal delivery, it's safe. But if viral load is high and she goes for a vaginal delivery, then the chances that the baby will get an infection is another 10%. So that has to be taken care of. So ideal would be cesarean section, no breastfeeding, and mother taking the drugs. That's the best combination that you can offer. So this mother opted for prevention. She said no, she doesn't want to terminate her pregnancy. She wants to do cesarean. So the next options that we gave her. Now what are the options that you can give her? Option 1, she takes zidovudin till delivery. At the time of labor, she takes 1 dose of nevirapine. Nevirapine has a very long half-life. It has a half-life of 3 weeks. You want to prevent HIV in the baby, but at the same time you want to prevent resistance in the mother. So no resistance. So to prevent this one from becoming resistant because of its long half-life, the mother should take zidovudin, lamivudin for 1 week. So she becomes actually triple drugs for 1 week. So she took, either you give zidovudin till delivery, single dose nevirapine at the time of labor, followed by a tail of zidovudin, lamivudin for 1 week. This is just, that tail is just for the mother to not get resistance to nevirapine. That is one option. Second option is she goes on triple drugs, right till her delivery and later on. So these are the two options. What does America do? America does triple drug. What do WHO do? This is what they do. What do we do at our center? This is what we do. Why we don't use triple drug? One, because of the cost. Second, we don't know the side effects, long-term side effects of these drugs onto the baby. These are teratogenic drugs. And we are very happy with our results. Our transmission rate is around 1.5 to 2% with this protocol. So if we are achieving that by doing this without causing much side effects, we are happy. So we are not following this. But this would be an ideal regimen. So both are right in its own place. You have to select what you want to do. Now delivery. Vaginal delivery or cesarean. If viral load in the mother around 38 weeks is less than 1,000 copies, she can safely go for vaginal delivery. If it is more than 1,000 copies, she has to undergo a cesarean section. So you have a choice of delivery that you will offer. Now what about the baby? Two options. Either she breastfeeds or she does not breastfeed. Ideal is no breastfeeding because breastfeeding transmission is 15 to 20%. We don't want to do that. And it can occur anytime till the time she is breastfeeding. So if no breastfeeding, because this baby was exposed to HIV virus, just as we get a prick and we take prophylaxis for 4 weeks, this baby is exposed to the HIV virus and needs to take prophylaxis. So prophylaxis will be zidovudin for 4 to 6 weeks. Or you give little additional prophylaxis, you give single dose nevirapine at the time of birth. So one to the mother, one to the baby, and you give zidovudin for 4 weeks. So these are the two options that you can give if the baby is not going to breastfeed. But if the mother is going to breastfeed, she still says, no, I want to breastfeed my child. I have been told that if I don't breastfeed, the child will die of diarrhea. So she opts for an option of breastfeeding. Then what are the options that we have? Either we keep on giving nevirapine to the baby till the time she is going to breastfeed. So the baby can take nevirapine for 6 months, 9 months, 12 months. That is one option. We give zidovudin to the baby again till the time she is going to breastfeed. So again the baby can get zidovudin for 9 months, 6 months, 12 months, whatever. Or if we don't want to give drugs to the baby, we give drugs to the mother. So we suppress that virus in the breast milk itself. So we give the mother ART, triple drugs. No breast milk virus. She can continue to breastfeed. So these are the 3 options available. Now remember, these options have recently come. Till now only this was an option. No breastfeeding. Now these options with breastfeeding have recently come in 2009. We don't know the long-term side effects. of giving such prolonged drugs to either the baby or the mother. So this side effect things will come later, maybe 3 or 4 years down the lane. But currently this is a recommendation. We are not following this. We are following this. We tell the mothers, stay breastfeeding, whatever said and done. If you can avoid, you bring down your risk really significantly. And we are very happy we don't see diarrhea. Maybe the class of patients that we see is a different class of patients, and counseling them becomes easier. They are a little more educated. So we go for no breastfeeding. We give our baby single dose nevirapine and cytovolin for 4 weeks. But this is the options that you have. You select an option. Your goal is baby should not be positive, mother should not get side effects. That's your goal. If you can achieve your goal by selecting whichever option, you are correct. Okay? So no transmission of HIV, and select options which are best for your patient. Now this is what we have been doing. We give zygovodin to the pregnant woman from 14 weeks. We don't give any drugs in the first trimester. Until this mother was already so significantly having advanced disease and she was already on ART, then we continue the ART. But otherwise, we start from 14 weeks. We give single dose nevirapine at the labor, and then the mother takes a tail of zygovodin lamivudin for 1 week. We do a vaginal delivery. Viral load is less than 1,000 copies. We give the baby zygovodin for 6 weeks after birth, and we do not breastfeed this child. So this is what we have been following. We've treated around 1,200 mother-infant pairs till now, and our transmission rate is around 2%. So we are very happy with this model. We don't want to change our model. So that is what we stick to, because we are happy with that. So now this child received zygovodin, mother received zygovodin till delivery. She underwent a cesarean section. She did not breastfeed, and the baby was given zygovodin for 6 weeks. Now this baby is born healthy, 2.5 kg. Now what should we do? What are we supposed to do? First is we start this child on zygovodin, right? And then you want to do a PCR. Why do you want to do PCR so soon?
And then we can follow it up later on, just to see whether the antibodies are free.
If you do an ELISA today, it will be positive.
Because of the
mother's antibodies.
This will say the
So you want to do a PCR because the parents are so anxious on day one that they want to know that this child is positive or negative. Okay, so you are not wrong. You should be doing a PCR. But most important is take care of other things. Prophylaxis. When do you start co-trimoxazole? You will have to, as I said, PCT is very common in the first year of life. We don't know this child is positive or negative. So this child, we take it as exposed child, HIV exposed. So we will keep him on co-trimoxazole prophylaxis. Co-trimoxazole cannot be given in the first 6 weeks of life. Why? Very severe side effects of anemia. So you should try and avoid it in the first 6 weeks of life. So that is why we don't give co-trimoxazole in the first 6 weeks. We start after 6 weeks of age. So by that time, the child must have finished the zygovodin prophylaxis, and then the child comes on to co-trimoxazole. Immunization has to be given as per national or whatever IIP immunization protocol that you are following. And we have to ensure that this child gets a diagnosis, whether this child is positive or negative. So this child was given zygovodin for 6 weeks, co-trimoxazole started at 6 weeks of life. Now test of choice. We said ELISA cannot be done because false positive. Viral culture, there is a viral culture that is available, but those are done in research labs. You really don't get viral culture routinely done. I think there are 2 or 3 labs in the world who are doing viral culture. P24 antigen, but not reliable in infants. For adults, we do P24 antigen in the window period before the antibodies form. But for children, P24 antigen is not reliable. So the only test that is left with us is a DNA PCR. There are 2 types of PCR for HIV. There is one RNA PCR and there is a DNA PCR. RNA is a quantitative PCR that tells me how much is the virus. So it's a viral load. Whereas DNA PCR is qualitative. It just tells me whether virus is there or not there. So it just tells me diagnosis of positive versus negative. So what we need to do for diagnosis is the DNA PCR. Now, how will you diagnose? You have a child who is born, she is breastfeeding. This child is being breastfed. Best time to do a PCR is 6 weeks. Intrauterine transmission you can diagnose at birth. But if the child was born vaginally, the virus to become positive by PCR would take another 7 days. So intrapartum would become positive by 7 days. Breastfeeding transmission can take later. So the earliest by breastfeeding you will be able to diagnose is by 6 weeks. So instead of doing so many PCRs, if this child is breastfeeding, let's just do a PCR at 6 weeks. 6 weeks positive test. Never label a child positive on the basis of one test. That's a dictum in HIV. No one test and label as patient as positive. Always do two tests positive, label positive. ART centers and everywhere they do 3 tests, 3 ELISAs, out of which 2 have to be positive. So if you do 2 and both are positive, this child is HIV infected. At 6 weeks if the test is negative, it does not rule out that he won't get HIV. He is breastfeeding. So this child can get HIV later on. So you have to again do a test after the mother stops breastfeeding. So if she stops at 9 months, repeat a test at 11 months. If she stops at 6 months, do a test at 8 months. So repeat a test. If that is positive, repeat HIV infection. If that is negative, this child is not infected. So that's how you will be doing PCRs for breastfeeding child. Whereas if the child is not breastfeeding, we know that the transmission would have stopped at intrapartum. After that, this child is not going to get it through breastfeeding. You do a PCR at 6 weeks. Positive, repeat, positive, HIV infected. If it is negative, he is not HIV infected. So non-breastfeeding is simple. Is it clear? Yes. Yeah. Now this child, 6 weeks, he has an oral thrush. There is no organomegaly, no lymph nodes. He is growing well, 3.5 kilos. We started cotrimoxazole prophylaxis and advised regular follow-up.